outlined maybe 4 sort of areas: communication, politics, partnerships, and infrastructure. Sort of maybe not the best order, but I'll just go with it from that. As you mentioned, just one of the lessons I think that we've learned, how important communication is. Being able to connect with our audience, whether it was magic or whatever. Yeah, I mean, but it is so important with everything that we've been dealing with. Is from the start, I think that is a lesson that we've seen. That needing to build trust with the community and with the public regarding what's going on. I mean, there's a lot of mixed messages out there. So however we can communicate that is really important. I think, one of the early things that we encountered locally, with testing and all the questions that were coming up about testing and testing capacity. And, we just didn't have a lot of answers early on. And, you just get beat up because you can't answer these things about, well, how much testing, is available, and it's still, the testing situation is not totally solved. But I think what, we've learned, I've certainly learned, and I think it's probably a principle of public health communication and risk communication, some of this, to try to be as transparent as you can. And you tell people what you know, what you don't know, and what you're trying to do about it are some of the principles. But I would say, again, I would be interested in hearing others' thoughts at the end of this, what you think about the communication issues, because again, there are so much that we have to communicate during COVID-19. I mean, and the Judge Jenkins has been great and been fantastic to work with, and as a leader in our community. I mean, such a privilege to work with him, because he is such a good, communicating. Early on, we're doing the daily press conferences to keep people up to date. What are the numbers? What's going on with our labs? All these things. But I'll say, in terms of just our need to keep doing that, I mean, these are. It's been the communication of all the various issues that have come up with this has been, it's changes every day. I mean, and that's another thing that's been unique with COVID. I mean, this is a brand new virus. We said we don't, we're learning something new every day. And so that communication and the different messages, even when the messages change, and, we remember when early on they're saying, masks aren't helpful, and we have to, how do you pivot and change that message? And you have to sort of explain why the message changed. It was really, I think, the importance of the asymptomatic spread, that people could not even know they have infection, not have any symptoms, and still be spreading this. And so that's where wearing masks, preventing those droplets from being transmitted when people don't even know they might be sick, is so important. And again, that's just one example of the type of communication challenges we've had, when there's been all the numbers, and then we're getting these labs that are months delayed coming from the state health department and all these systems. Again, we've got to communicate what we know about the data, because so many important decisions are being made based on this data, whether, workplaces and stores and bars and restaurants and things open, whether schools open or close. All these things are so important on these numbers and data, and how we communicate that, and the problems that we're having and the current status of those numbers. We just have to try to explain why we're doing what we are, what we currently know, what the problems that we're having with the data are, and hope people will understand and understand the message. And as was mentioned, have to try to make it in a simple terms that people can understand, and not to, us in public health have this tendency, and I probably still, do it, to just be too technical or whatever. But how do we make it so everyone can understand these things? But again, also when there are competing messages, and when there's competing messages, whether masking or even taking this seriously is important. I mean, this is where just how do you communicate that? Second thing, I mentioned in terms of what we've learned so far, politics, how big politics plays a role in this. When I started out my public health career, I know one of my supervisors said, I mean, just a significant portion of what we deal with is politics, because just from the standpoint of, I mean, we're in, and certainly in a local health agency, you're in a bureaucratic governmental structure, whether at the county level, the city level, the state level, or federal. There are a lot of political things that can go on. What we've seen, again, the politics, certainly a lot of politics going on at the federal level right now regarding it. A lot of finger pointing, a lot of blaming or claiming, what the current situation is what we dealt with the state, and that interaction between the state and the county and local level, between the governor and Judge Jenkins, just a lot of things that are going on, and especially even more difficult when there's so many unknowns and the situation is changing. So whether it's, that there are now federal resources that are coming to stand up a, makeshift hospital at K. Bailey Hutchison's Convention Center, and, what's going to happen to that, those sort of questions, or the politics of when the hard decision needs to be made, that the data and the science is saying this could be really catastrophic, and we need to do something like a shelter-in-place order, or stay home, stay safe. There have been certainly politics about that early on. Then when those hard decisions needed to be made, there was some decisions that at the state level to make it then local control to decide when to close things down. And then when it came time to open up, then there were decisions that were made at the state level and that preempted and took away then local authority to make any decisions that were contrary to what the state level decisions are. Again, initially say local control, and then later say there's not local control. So these are all political things, I think, that we've seen. And the local control issue extends to many different areas, and it's it's going to be probably a hot topic. It was a hot topic in the last state legislative session. It'll probably be a hot topic this next one. But it's sort of interesting how at the state level, the state would be outraged if the federal government said, well, every state is the same, and so we're going to usurp and take away state levels to make decisions and just do it all at the federal level because all the states are the same. But then how at the state level, decision could be made that, well, we think all the counties and all the cities are all the same, that Lubbock and Amarillo are the same as Dallas and Houston. And so decisions should be made at this state level and sort of not allow local control that, so it's a politics that we've certainly seen a lot of that throughout the COVID-19 pandemic. And so certainly lessons learned regarding how that plays into what things we're going through. I'll skip to infrastructure was a third sort of topic I mentioned. And one of the things we've certainly learned is that, the public health infrastructure has not been well invested in over, in between major, public health events, whether in between Ebola or H1N1 or Zika or West Nile virus, people forget about public health. When public health is doing its job, things are quiet and people don't know we're doing anything, whether it's, inspecting restaurants and trying to keep the food safe and prevent foodborne outbreaks, or getting people immunizations so that we don't have vaccine preventable diseases, or other things, and monitoring, the data and monitoring what's going on. Until something bad happens, people don't think about public health. When people think about health, they think about clinical health care. And if you look at, it's like the comparison of the amount invested in clinical health care versus prevention and public health, it's staggering. We're just like a percentage of what small fraction of what is invested in healthcare. There's no questions, or people don't blink an eye when they say, hey, we're going to spend all this extra money on new CT scans or MRIs or new medications and treatment. But then when we talk about, investing in public health, maybe data systems or things like that, then it doesn't get that same level of support typically. Like, again, whether a lot of investment in hospital and, electronic health records at clinical settings, but there has not been that investment in the data infrastructure for public health. And what we found with this, we have, and we do a lot of things in public health day in, day out, whether it's monitoring TB or sexually transmitted diseases and following up on those cases and doing what's called contact tracing. Again, contact tracing is a hot word now. People now have suddenly newly discovered this, but it's what we've been doing in public health for years, for STDs and TB. But now with COVID-19, everyone, is now attuned to it and wanting to get in on it. But the data systems to support that, we've historically maybe been able to handle the few TB cases or the number of TB cases we get every year. But when we've got, 80,000 COVID-19 cases, then our systems have not been able to keep up with that. And so we've seen that at the state level. Some of the data systems were the systems were so old and sort of archaic. They had, the limit of, I think, 50,000 records a day they could handle. When the state started getting more than that, then all these new cases of COVID-19 got backlogged. When they finally were able to upgrade some of the systems, and all these backlogs of cases started coming through the pipeline. And so we're getting, one day we had 5,000 new cases reported from the state health department. But then also, people don't realize every day we get hundreds of paper faxes with lab reports coming from various, physicians' offices, other healthcare providers, that these data then have to be hand entered into some of the data systems. And, the data is so important, as people have seen. The numbers of cases and what's going on and who's being affected and all this information that we collect. Again, what are the demographics of who's being affected? What are the geographic locations where these cases are occurring? What are the trends and numbers and how many are being hospitalized? All this information is what we're using to make these huge decisions that are affecting trillions of dollars in our economy, our workforce and business decisions of whether businesses will be open, whether schools will be open or closed. And we have not made adequate investments into these systems in between these times. And it's showing, hold on. Sorry, I was trying to get a message out of the way. I think that's one lesson that we've also learned so far, that we do need to make these investments even when it's quiet, and that public health really is at least as or more important than all the investments that we make in clinical healthcare. The last thing I want to close with in terms of sort of a lesson learned is under the category of partnerships. And, I throughout this, we can't, it's taking all of us working together to address this, in all avenues. I know just one of our big partners, Parkland Hospital, has been a tremendous partner in terms of, when we need testing centers and drive-through testing sites. They've used their staff to help man these things. We're having to work with all the hospital systems, the clinical healthcare providers, trying to get all this information. Other community partners, whether it's business, whether it's academic centers, the medical school, everyone to try to work together, the schools, to help work together to identify what is best for our community in terms of, given where we are, what are the recommendations that need to be made regarding people going back to school and teachers going back to school and workplaces, and how do we best open up so the economy in some of these places safely together. These are all decisions, and some of the partners obviously haven't been happy necessarily with some of the decisions that have had to be made. But I mean, I think what's been learned is that to open up the economy successfully, you've got to first successfully battle this condition and address COVID-19. If you don't get it under control, then things will not be able to open up, and you'll have even more problems in the long term. And that is, I think, a lesson that has been learned. But this has been an unprecedented, once a decade, once 100 years type of event for all of us who a year ago would have expected that we would be where we are. I remember even in, I think, March, we're having these discussions with school districts and school superintendents and saying, you really need to be seriously looking at your plans for remote learning. But at that time, I don't think people really thought it could happen. And again, we've sort of moved into it. Now this is the new reality. It's some of the other challenges, going back to communications in a way. We know what works. If people will continue to do the universal masking and 6-foot physical distancing and not gather in crowds and wash their hands and all these things, it's not magic how it spread. We know how it spread, and the things that people can do to prevent that. But we're all human. People are human. They get tired of all this and let their guard down, and things start getting opened up, and people start thinking we can go back to normal, the old normal. And but a lesson that's been learned from the start. Our community did make the sacrifices when we first did the shelter in place and stay home, stay safe, and we truly flattened the curve. I tell people that there are people alive I know that would not have been alive had those decisions not been made. Yet we still have to stay vigilant on this and keep doing it. So let me stop there. There's a whole lot more lessons learned, I'm sure, but that's certainly a handful there.
So we thank you for all of that. We do have a lot of different questions. The first one is, do you believe that the U.S. is entering into the second wave of the virus? If you agree that there's a second wave is here or approaching, what do you recommend for the immediate future?
So you're probably aware, yesterday we in Dallas County we had been in the orange level of sort of transmission risk in Dallas County, and we went back up to red. We've been red throughout the whole early part. In September, then we were able to go back down to orange, but we had to go back to red yesterday because we're seeing some worrisome, for the last about 3 weeks, worrisome increases in a lot of the indicators like emergency room visits, hospitalizations, hospital admissions, that are all consistently showing that things are going back up and in the wrong direction. We know that this has been, as schools have been opening, as colleges have been coming back, as now that the governor and the state have now started increasing the percentage that they recommend people go into restaurants, and that they've made it an option for bars to be open. But we know even with the bars, even though there were the restrictions, that there was a lot of people getting around that by just getting over 50% of their revenue from food and starting after more food trailers or something as part of their services. So it's, the indicators are worrisome. We know what, if everyone would stick to the the universal masking and the avoiding crowds and 6-foot distancing and all these things, and be vigilant, we know we can control it. But with all the factors that are coming together, I think we're seeing these increases, and throughout the country, And as we get to the winter months and where it's cooler and people have to stay inside more and in more closer quarters, and that again is another factor that can make this second wave. So it is certainly, we're seeing this happen. I don't think it's inevitable in the sense that we can control it if we really stick to the things that we know work very, vigilantly.
So there's kind of a new thought process where people are becoming a little more comfortable with the outdoor events. What are your thoughts on drive-through and outdoor networking events, assuming that people are wearing masks or not wearing masks? Do you have any comments on that? Do you feel like those are safe or not safe?
So, and I'd recommend people go to our guidance document. It's on our website, dallascountycovid.org. But we've had a guidance document that summarizes what our own local experts, infectious disease, epidemiology, public health, have made for different scenarios. Let me plug in my phone. And so what do we recommend for outdoor gatherings or for restaurants and bars, and based on the color risk level that we're at. I do think outdoors is better than indoors. Greater distance is better than less distance. Again, the universal masking is so key. So I think there are things that we've learned that if it's truly adhering to being outdoors and physically distant and not mixing with crowds, you can do that safely. We've supported people exercising individually outdoors and doing things. It's the group things, and it's really looking at, are these going to be truly adhered to? There are, when we're in red, there are recommendations that not to do groups greater than 10. And so those are certainly best, the practice that we would recommend. So it's with those, I would recommend people go look at the guidance document.
Awesome. Our next question has to do with the risks of isolation versus COVID. So to those of us working with seniors in long-term care or assisted living, we're worried about the health risk of isolation versus the COVID exposure from visits. Are you familiar with the study in Norway where they concluded with careful monitoring, they could allow family visits? And are you considering this issue?
I think it's a very valid issue, and have seen certainly firsthand that particular situation. It's this balance and trade-off to make sure that the infection control procedures and our things are really strictly enforced. And certainly if you can do that, then you can allow some of these other things to occur. But the question is, in practice, are they going to be adhered to? And so, that's the question. And I do think, and we've seen decreases in our mortality rates related to COVID-19. I think a lot of that is because of improvements in the long-term care facilities, their ability to do the infection control and what's been learned about this and the management that in these settings. And that, the fact that then now a greater percentage of the people being infected are younger populations. And I absolutely, it is so tragic and sad when, persons in the long-term care facilities aren't able to have the interactions with their family members. So I am extremely sympathetic to that. And so I think everyone's looking for, how do you truly do it safely, and have the policies that support that.
Great. Our next questions have to do with the vaccine. Will the vaccine be encouraged and prioritized to vulnerable patients, or will it be compulsory for everyone? And then the second piece to the vaccine has to do with availability. When do you feel that there will be availability in the DFW area once the vaccine is available? How quickly do you think it will be available to those in this area? Has is there vaccine on order for our area, etc.?
Can you say the first part of the first question? Because I got a call at the same time and I was trying to get rid of it.
So the first part is, will the vaccine be encouraged and prioritized to vulnerable populations, or will it be compulsory for everyone?
Sure. No, absolutely. When it's initially, released, there is plans to identify the high priorities, because there's not going to be enough for everyone to get it in the first, couple months as anticipated. It was like H1N1, and so there would be prioritization to frontline workers and the highest vulnerable populations are some of the target populations that are being recognized that needing that. But I don't think it will be mandatory at this point. I've not heard that. I think there will be certainly a lot of people from wanting it and clamoring it. Although, then it depends on, I think that there's trust issues. And I talked about communication and trust, given if there's political agendas to try to get things out sooner than would be recommended, and then going through the proper processes. I don't think it will be mandatory, largely because of that too, because of some of that distrust with things. I think that it will probably be quite a few months before it's really readily available in the county. So maybe by early, it's hard to speculate. Yeah.
Okay. The next set of questions has to do with the COVID tests that are currently on the market. Can you tell everyone the top 2 or 3 COVID brands and manufacturers based on accuracy and results response time? And then I'll ask the second part separately.
Yeah, I mean, the whole testing situation it's been the Wild West, and all these new tests coming out, then the huge demands on the tests causing the backup and the delays in reporting. I mean, the gold standard type of test are the PCR tests that detect the RNA. They're now, I know with our sites that we're working with Parkland at, like the drive-through sites at Ellis Davis and at Eastfield College, they're getting a turnaround time of 35 hours. There are now the antigen tests, antibody tests. It's the antigen, that are more the rapid 15-minute tests. Those, if you look at the way we categorize cases, the only ones that count as confirmed cases are those with what are called molecular amplification tests, like the PCR test. The antigen tests, then those, when you hear us talk about probable cases, because of some of the limitations, there's more false negatives on some of those tests. So you get a negative and it may be falsely negative. So more of the gold standard is the PCR test, but then even, after someone tests positive for that, then the PCR test can keep showing a positive result, several weeks afterwards, because they still find fragments of the RNA, but then you're not actually communicable. So, there's a lot of limitations to all the various tests. The antibody tests tell whether you had it before, but again, those are have a lot of limitations in terms of the quality. So I can't tell you. I mean, what I would say, the definitive ones are for the PCR tests. Right now, there's better turnaround times than there were in mid-July when all the labs were being overrun with numbers, but we'll see. And it keeps changing. This is the thing with this whole situation; it changes every day. So.
Yeah, I think that we're all potentially a little frustrated because we're not 100% sure what the accurate information is, and so we don't really know how to direct our clients sometimes when the information that we are receiving ourselves can be confusing.
Right.
The next question has to do with, again, the COVID test. Is the FDA approved mouth throat swab as accurate as the nasal swabs?
So it depends, and you can't. It's like different. There's so many different laboratories, the different procedures that they get approved through the FDA on this collection methods and things. So it's hard to, you can't say a blanket statement like that. The nasopharyngeal swabs, those uncomfortable ones where swab goes all the way back into the nasopharynx are the most accurate. They're still looking at saliva, other testing. So, and again, it can vary by different laboratories too. So it's hard to just say that blanket.
Okay. The next question has to do with UV light cleaning. And do you feel like cleaning with UV lights in a neighborhood-based assisted living communities is effective?
There are some EPA approved, cleaning agents that are out there that I've seen some of the things on the UV light. I mean, it can be effective. I think that, they said, I guess I'd look to, look at the CDC recommendations on that. There's been some, it's not the primary means of transmission. It's more the droplet spread and things, but that you can get it from surfaces. So you need to keep doing the environmental surface cleaning. But I think that it's debatable how much to put into some of these other systems. So again, it's not a definitive answer. Sorry about that. But I mean, there's certainly some benefits to these, and they've been shown to be effective. But it's debatable how much to put into each one of those.
Okay. And then I know that we talk a lot about the COVID positive rates, and we look at, how those are going up. And the question is, should we be paying more attention to the mortality rate to understand the severity of the epidemic, or do you feel like the COVID positive testing rates are the more important thing to be looking at?
From the start in Dallas County, we've been saying it's more of we've been looking at all the data, including positivity rates, the numbers of new cases reported. But we've said from the very start, it's really some of the hospital data that's not as dependent on things like testing or who's getting tested or that, because, whether someone gets tested or not, if they develop symptoms and become severe enough that they need to go to the hospital and visit the emergency room, that's sort of independent of the testing. If they're severe enough that they need to be admitted to the hospital or admitted to the ICU, that's again independent of how much testing or who gets tested or availability or turnaround times or all these things. And then, it's a trailing indicator than the mortality and the deaths, but certainly that is independent of test availability or who's getting tested. So we've been looking, and when we just went from orange back up to red, some of the most concerning things were the increase. I think we had a 27% increase since September 25th in emergency room visits. We had a 44% increase in hospital admissions. That those indicators, again, that are less dependent on testing or testing availability. The problem was, like, even when the governor first opened up and said, hey, our positivity rate is 3% or something, it was like following there being this big massive testing outreach effort in rural communities where they had almost zero cases. And so, if you sort of flood the tests with those persons, it's different than if you're only testing people in the hospital or in the ICU or something. And, even when we look at some of the hospital rates, we look at, okay, and that's a better turnaround. You can, some of the hospitals change some of their policies on their testing, that they're going to start testing every person before they go to surgery for any problem, if they're asymptomatic, or they start testing every pregnant woman who comes in to deliver a baby. Well, that's different than when you're testing just people who have symptoms. So I've never really been a big fan of the percent positivity rate. It's one of the indicators we look at, and if there's uniform testing going on, that's fine. But again, some problems with it.
Okay, thank you for sharing that. Another question has to do with our Black and Brown communities. Has the positivity rate increased in those communities? Are we still seeing a higher number of cases? And has testing increased in those areas? And then in addition to that, a second part is how are their outcomes looking?
So, you know, we have certainly seen disproportionate impact on various populations. In Dallas County, it has been most seen in the Hispanic community. And, you know, also in African American community, but not as much disproportionately compared to the, you know, represented, but it's certainly severe. And the whole South Dallas area, the typical areas where we see higher areas of vulnerability and disparities have had greater need. But in particular, the Hispanic community, largely, you know, a lot of frontline essential workers, also some concerned about, you know, some of the household situations, maybe, you know, multi-generational families in those households, and, you know, more persons living in the same household possibly, but various factors. So we are very, you know, concerned about that, have been attuned to that, and have tried to target, you know, really all of the testing efforts and other things that we have control over into those communities.
Awesome. Well, thank you so much, Dr. Huang, for sharing all of that great information with us. And do you have any final words for us?
Wear your mask, the universal masking, try to keep physically distant 6 feet, avoid crowds, especially if you have high vulnerable, if you're 65 or older or chronic health conditions, really try to avoid crowds. The holidays are going to have to be a little different, unfortunately. You know, you might have to be more virtual, but we will get through this. Wash your hands, don't touch your eyes, nose, and mouth, and get your flu shots.
Awesome. Well, thank you so much. We really appreciate your time today.
My pleasure. Thank you.
All right. Let me see if I can get our presentation back up here. Some great information from Dr. Huang. Thank you all for all those great questions. We have been navigating through 3 different Q&A/chat boxes, and so it is a combined effort. Behind the scenes here, you have Susan, Peggy, and I all looking at different areas to make sure that we address all of your questions. And Peggy is trying to say hello to you all. I'm going to fix our little screen here so you can see our backdrop. And we just have our closing remarks now. I'm going to let Susan start.
I just want to say thank you to everybody for your patience with us as we've all learned this, and to our sponsors, thank you for believing in us when we came to you with the idea of, you know, a lot of people said, oh, maybe we shouldn't do the Fall Forum this year, or we won't be able to do it. And so we tried to find a way, and we appreciate all of you trusting us to find a way. And I hope you've had a great experience today. I know our speakers have been amazing, and I've seen so much interaction between all of the participants. So I just want to say thank you to the sponsors, to the exhibitors, to the speakers, and to all of you who make DAGS what it is. I was trying to think back to when I started to be involved with DAGS, and I started in 1993 in Denton, and I remember getting in the mail a folded up piece of paper, you know, with a mailing label on it and a stamp with an invitation to the DAGS meeting for that month, and thinking to myself, oh wow, DAGS, that's like where I want to be when I grow up. And so here we are, and I'm really grateful for that. So I guess thank you to everybody who's participated in every way. And I think this is going to be a great DAGS year. So I'm really looking forward to that. And I'll turn it back to, I grew up, Cheryl. I grew up, up and out. So I'll turn it back to Kathleen and Peggy.
Peggy, do you want to give your final words for today's forum?
Pretty much like Susan, I am just so grateful, as my picture, my emoji, Bitmoji says, for all of your help and support Can't believe we made it to today, and guess what? 365 days till Forum 2021.
So I want to remind you all to complete your evaluations. Make sure that you do that. I will stay on it at the end here to help you all find your evaluation on your desktop or your mobile app to make sure that you can find it. I want to thank again our sponsors and exhibitors for their generous support of the DAGS Scholarship Program. I want to thank my fellow forum committee members, Peggy and Susan, for all of their hard work and their enormous contributions to the success of today's events. And I also want to thank the DAGS board and you, the members of DAGS. Without you, the society would not exist. We so appreciate you all. And DAGS is truly a community of people with a passion of serving older adults. And so let's advocate, let's educate, and let's serve our older adult community. So I thank you all for being here today. And that concludes our program. Thank you.
Bye, everybody.
Bye, everyone. And let me just see if there is anyone who needs help to find. If you need help to find your survey, please let me know.